Acute aortic syndromes are a group of diseases that have many overlapping features. These include aortic dissection, penetrating aortic ulcer, and intramural hematoma. All of these syndromes usually present as acute tearing chest and/or back pain. Patients can present in a similar fashion with pulmonary embolism, acute myocardial infarction, and other thoracic emergencies. However, for the simplicity of this video, we will focus on aortic dissection, penetrating ulcer, and intramural hematoma. Patients are usually hypertensive upon presentation. However, a hypotensive presentation indicates poorer prognosis. Patients can also present with symptomatic branch occlusions in almost 1/3 of cases, such as stroke, spinal cord ischemia, abdominal pain, or limb ischemia. Rarely patients present only with limb ischemia. So what exactly is the pathophysiology between these entities? Acute aortic dissection is probably the one most students are familiar with. Aortic dissection is caused by an intimal tear with propagation of blood flow into the subintimal layer of the aortic wall. This means that the blood at systemic arterial pressure fills the new space, so the aorta will contain two different spaces. The space lined by the intima is termed the true lumen, and the blood within the media is termed the false lumen. The entrance tear is most commonly seen in the right lateral ascending or proximal descending aorta. The most common risk factor for aortic dissection is hypertension. Other risk factors may include trauma, Marfan syndrome, Ehlers-Danlos, cocaine, and more. In intramural hematoma, the suspected etiology is thought to be spontaneous hemorrhage of the vasa vasorum into the abnormal medial layer in the absence of an intimal defect. So unlike penetrating ulcer or dissection, there is no communication seen with the lumen. Intramural hematoma is usually seen in the proximal descending thoracic aorta, but mortality is higher when it's in the ascending thoracic aorta. Progression to dissection with intimal tear occurs in approximately 1/3 of cases. This indicates that intramural hematoma may be the precursor for aortic dissection in many cases. Risk factors for intramural hematoma are similar to aortic dissection. Penetrating aortic ulcer is the result of unroofing of the atherosclerotic aortic intimal plaque. This results in a focal, partial, or full thickness defect in the aortic wall. These ulcers almost always occur in the setting of a pre-existing aortic atherosclerosis, most commonly in the descending thoracic aorta. Evidence of intramural blood, periaortic stenting, pleural effusion, focal aneurysm formation, and periaortic hematoma should also be present. It's important to note that irregular and excavated appearing aortic plaque is a prevalent finding in asymptomatic patients with severe atherosclerotic disease, so correlation with other imaging findings, such as reactive changes or adjacent hematoma, and clinical presentation is essential to avoid overcalling these lesions. CTA is essential for the diagnosis of aortic dissection and penetrating ulcer. However, a non-enhanced CT is helpful and especially important for the diagnosis of intramural hematoma. Therefore, the CT protocol should include both non-enhanced CT and CTA. With a simple and single sentence, we would describe the appearance of these identities with the following. Aortic dissection will show aortic intimomedial flap on CTA. Intramural hematoma will show a circular or crescentic aortic wall hyperdensity on non-enhanced CT. Penetrating aortic ulcer will show contrast outpouching beyond the aortic wall. Here we have a CTA of a 65-year-old female with severe chest pain. The CTA shows an intimal flap with contrast filling in two lumens separated by the intima. This is a classic appearance of aortic dissection. Sometimes it can be difficult to see which lumen is the true lumen and which one is the false lumen. One trick is the bird beak sign. Since arterial pressure is usually higher in the true lumen, the intimal flap will be pushed to the false lumen, creating a beak at the ankles. The bird will be located within the false lumen. In this case, the dissection involves the ascending aorta, so this is classified as Stanford type A. If the dissection only involves the descending aorta, it is classified as Stanford type B. Rule of thumb is that Stanford type A dissections are surgical emergencies, but type B can be treated conservatively. However, interventions are sometimes indicated with complicated type B dissections, for example in branch occlusions or rupture. In this case, we have a 65-year-old male presenting with an acute tearing chest pain. A non-enhanced CT shows hyperdense crescent hematoma in the aortic arch and down in the descending aorta. The CTA shows no connection with the lumen. This is a classical appearance of intramural hematoma. This shows that non-enhanced CT is essential in these cases since a thrombosed false lumen can simulate intramural hematoma. However, a thrombosed false lumen is typically not hyperdense on non-enhanced CT. And finally, we have another case of a 65-year-old male with sudden onset chest pain. In this case, the CTA shows an outpouching of contrast extending beyond the estimated aortic wall. Adjacent, we have a mediastinal hematoma that compresses the pulmonary artery. This is a classic appearance of a penetrating aortic ulcer. I hope you found this video helpful, and if you'd like to see more content like this, don't forget to like and subscribe. I hope I see you in the next video.